Okay, welcome to Pathophysiology, an introduction. This is just very basic. It's kind of like chapter one, bunch of definitions, but there's some important information that you need to know that you will use like forever in your nursing career. So I want to share this with you, and I think this is going to be a fun little lecture. All right, who am I? I'm Victoria Krejci Kitchell. I have a master's degree in nursing, post-grad work in nursing and healthcare education. I'm a nurse, and I'm certified as an emergency nurse and as a flight nurse. So, pathophysiology, break that apart. Two words, actually. Part of that is pathology, the other part is physiology. And you probably already have an idea of physiology because you took anatomy and physiology before you got into this course. So, pathology, the study of the nature and cause of disease. That's from Tabor's Medical Dictionary. So, pathology is like the stuff that goes wrong, and we're looking at the details of the stuff that goes wrong. All right. Another definition is pathology is the study and diagnosis of disease. And so, saying the same thing, just little different words. I kind of like the way that's worded, is that we're talking about disease. Pathophysiology, the patho part is disease. All right. Physiology is like what you already did in anatomy and physiology. Here we're looking at the science or the study of the functions of the living organism. So now we're looking at normal. We're looking at cells, tissues, organs. How do those work? All right, another definition, sorry, is the study of the functions of living organisms. And we're in nursing school, right? So we're talking about people. You can apply pathophysiology to, all creatures on the planet. We're we're talking about people. So pathophysiology is the study of how normal physiological processes are altered by disease. Like that definition, that's a good one. And another one, the study of abnormalities in physiological functioning. Okay. All right, we beat that horse down. Diversity, really important to identify that no two humans are exactly alike, which I think we pretty much know this, but we have to apply that to disease. So we have an awful lot in common, but we're not identical. So not every single patient is going to present to you exactly the same way when they have the same diagnoses. However, like I said, we have a lot in common. So you might wonder if everybody has a heart, but we know everybody has a heart. There's an odd person out there from time to time who has the heart on the right side of their chest, but for the vast majority, we all have a heart on the left side of our chest. Okay, I like this one. Pathophysiology is identifying the typical abnormalities. So, like I said, not everyone's going to present with the exact same set of diagnoses, but they're going to be close. And when they list off their signs and symptoms, they're going to raise these little red flags for you, and you're going to go, oh, yeah, I have an idea what this is. No, we don't diagnose patients, but we have a clue. All right. So, like I said, where we talked about anatomy and physiology, you totally identified normal. Now we're looking at abnormal. Okay, there's 4 constructs that you need to know about this, though, because when you think about the abnormal, then what are we going to do about it? So, pathophysiology is like this framework, and we look at etiology, pathogenesis, clinical manifestations, and treatment implications. And this is how we take and we add nursing to what's going on. All right, so etiology. Super simple. What is the cause? Sometimes we don't know. Sometimes we have a really good idea. There's actually a whole list of causes that we're going to look at. Congenital, right? We're born with it. So it could be cleft lip, could be um, down. Well, no, I don't want to go into that. Anyway, congenital abnormality. Something happened in the actually, it could be Down syndrome. Sorry about that. Um, anyway, if it's a congenital problem, it could be heart problems. That's really common. And we see like tetralogy of Fallot, some of those kinds of things. You'll get into much more detail later in this course. And then, of course, again, in pediatrics, in OBGYN, in med surg, et cetera, et cetera. All right. So degenerative things break down over time. But you're going to see people with a diagnosis of degenerative joint disease or degenerative, excuse me, disc disease. And so you're going to identify with that. These are things that are just breaking down over time. Some people are prone to having that happen much sooner, but eventually we all break down over time. All right, iatrogenic, caused by medical care. What does that mean? That means it's not that we're doing harm, but it's like a side effect. It's a new disease process that's a side effect of the medical care that we are giving. And so, say chemotherapy. Patient goes, they have breast cancer, they're getting chemotherapy for their breast cancer, but now they have sores in their mouth and the lining and diarrhea, the lining of their GI tract is a mess and needs to be healed. Well, that's because chemotherapy stops the growth of new cells. And so we are constantly turning over the lining of the GI tract. That's mucous membranes all the way down. That lining is constantly being regrown over and over and over and over. But now with the chemotherapy, it's not. And so it's breaking down, it's sore. We're not producing the new tissues to replace what is like burned off, kind of. And so, yeah, anyway, iatrogenic. Iatrogenic cause, etiology is iatrogenic when something in healthcare is causing this new disease process. Okay, idiopathic, we have no idea. If it's idiopathic, it's something we don't know. So these are the 2020s, right? Like I'm actually producing this in 2021, but you think we should know everything because we're so smart and we have all this technology and all of this knowledge on the planet, and we don't. Healthcare is really fairly young. We have tons of wives' tales out there still. We have a lot of science, but we still don't know everything. And every once in a while, somebody will present to you, and we have no idea where it came from. It just did. Okay, immunologic. So it's related to the immune system. And here we see like autoimmune diseases, um, uh, multiple sclerosis, or rheumatoid arthritis. Some of these where we're attacking ourselves, or for some reason the immune system is not functioning properly. All right, infectious, obviously, bacteria, viruses, there's a whole slew of infectious processes that can cause disease. I'm not even going to get into COVID. Inherited. So now we're talking about a genetic disorder. Yes, that is going to lead to a congenital presentation, something we are born with, but it's something that we can go back to and we can see that our parents actually had the genetic markers to make this an issue. For example, they think rheumatoid arthritis, lupus may be congenital, but we don't know that for sure. But something like Huntington's chorea, we know that is a congenital inherited genetic disorder. So You're not going to see signs and symptoms when you're born. So you're not really going to identify with a congenital problem, but you are going to go, oh, that's genetic. That's an inherited issue. Okay, metabolic. Metabolic, we're talking about problems with how the body metabolizes, say, sugar, and we get into diabetes. That's going to be a metabolic cause. Neoplastic cancers. Um, Nutritional. So here's where we get into things we don't see a lot in the United States, except for obesity. We see that all the time. Technically, I'm obese. Not morbidly obese, but my BMI is like right on the edge. I don't really like BMIs, but it is what it is. I'm still a little bit heavy and I could potentially have issues because of that. The other things that we're going to see though are like vitamin C deficiencies. But I think we do see vitamin D deficiencies in the United States, but that kind of goes with the obesity because we're not very active. Anyway, so nutritional issues. All righty. We're almost done. Physical agents. These are kind of fascinating to me. And I think of OSHA when I think of this. So it could be something like the sun, where we have a wicked sunburn, or we have heat stroke because we're working outside, we're in the sun, we're dehydrated, high altitude, some of those kinds of things, is a physical agent. But also say you're working with chemicals in your job, um, or radiation. You get actually radiation poisoning because it's very unlikely that that's going to happen in the hospital. But you could see somebody working in a nuclear power plant or something like that and having an issue. And you're going to see, actually, you might see neoplasms, but you're going to see an issue of whatever diagnosis is based on some sort of physical agent. And psychogenic. It's the last one. It does happen. We can create diagnoses. We can we can actually make ourselves sick. Um, this this gets tricky because when you get in with psych patients, you kind of are like, "Ah, but is this psychogenic or is this real?" And something that's going to be just incredibly important is that we must always respect that patient, and we have to respect their mental health as well as their physical health. And so sometimes it's easy to blow that patient off. It's also a really good nurse who's not going to blow them off, who's going to take them seriously until proven otherwise. Okay, that's a little soapbox right there, I guess. All right, so that is all etiologies. Where do disease processes come from? Pathogenesis, though, is like, how does the disease process develop? How does it progress? How does it evolve? So we're looking at, there was an exposure to the sun, lots of exposures to the sun, years and years of exposures to the sun. And then you have little changes in the cells of the skin, and those can progress to ultimately being neoplastic or it becoming cancer. We have growth of new and abnormal tissue, and now we have skin cancer. And how does that evolve? Sometimes that's a really bad cancer. And that could lead to just having, cancers removed from your nose or from your arms or from your shoulders, or the back of your neck is really common, all the way to that cancer can actually kill you because it is such a wicked metastatic type of cancer. All right. And don't worry about those kinds of details. We're going to get into those later. We will not ignore them. All right. So clinical manifestations. When I talk about that, I'm saying, like, what does it look like? What does the patient complain of? So let's just mention congestive heart failure. Someone's old, they've had multiple heart attacks. The heart just is simply not functioning anymore. We can go all the way back to the cells, and we will do this in this class, where the cells are damaged, they're no longer conducting electricity as like they supposed to, which means that they don't contract like they supposed to, and like they are supposed to. Oh, what's with my grammar there? Um, and so the cells are damaged, things are not working as well as you would like them to work, and the heart is ultimately starting to fail a little bit. But how do you see that? How do you know that? Well, you know that because it's not pumping effectively, which means fluid is backing up. The blood is backing up. So it's either backing up in the lungs, backing up in the feet. Their toes might look like sausages because they're so swollen. They might have so much edema and extra fluid in their legs that they're actually weeping, or it looks like their legs are crying because the fluid is just kind of oozing out of the skin. So we're going to see things like complaints. I'm short of breath. My feet hurt. My legs are so swollen and I don't understand why. I have to sleep sitting up in the chair. I can't lay down and go to bed at night. Those are clinical manifestations or signs and symptoms of this particular process. And so what you're going to learn in this class and in med-surg and other classes is that those are little red flags that take you to the diagnosis of congestive heart failure. And that, being a nurse, is going to take you through what nursing interventions do I apply to this patient to help them feel better. All right, and then we get into treatment implications. In pathophysiology, we're going to be more general. We're not going to be super specific. And so you're going to get that again, like I've said, med-surg and other classes. So we're going to stick to general treatment implications. Okay. We need to take a moment and talk a little bit about population health. It's a big part of pathophysiology, and it takes us to how do we prevent these problems? And so, population health. My guess is that you understand what an epidemic, a pandemic, I bet you understand those without any question. We're also going to talk about endemic, which is really important, especially if you travel. But my guess is in the era of COVID, you understand these really well. So an epidemic is that we have this burst of a problem in this community at this time. So we could actually see something like how COVID started. We could take it to COVID, might as well. And or flu. How did this start? So in Wuhan, it started out as a very small community where everybody had these odd symptoms, signs and symptoms. And that was eventually discovered to be a new virus. Turns out that virus is fairly contagious and we travel like we are all over the place, right? And so it became a pandemic because people traveled all over the place and now COVID is everywhere. So that's epidemic and pandemic. Endemic is that we're talking about a certain disease process that is endemic to a certain geographical area or endemic to a certain location. For example, malaria. That's a really easy one to look at. You can look at certain areas in Africa and malaria is huge, right? I believe it's transmitted by mosquitoes, and we just have it in that area over and over and over and over and over again. But it's not here in the United States. We don't see malaria. We see people who've gone to Africa who have caught and gotten malaria, who come home who are dealing with the diagnosis of malaria, but that's really not a super common thing. However, it's endemic to that area of Africa. For example, I went to Guatemala a couple of times and I needed to have my typhoid vaccination. Not to go to Guatemala, but to get back to the United States, actually, without it. They're like, no, we're not letting you through the border because we don't want you to bring typhoid back. Typhoid is endemic to that area, and there's too good of a chance of you getting it and bringing it home. Okay, cool. I don't want typhoid anyway, so I got my vaccination. Okay, endemic, pandemic, epidemic. I think you probably have that down. Okay, so here we go. Endemic, found in a specific population or region of the world. Pandemic, it is an epidemic that is super widespread. And epidemic, we already talked about, it's affecting a high percentage of people within a community. In the United States, one of our epidemics is obesity. The large community, but it's a pretty significant problem. So that's something to think about. All right, levels of prevention. So some people kind of want to focus on levels of prevention of disease. And when we talk about the primary level of prevention, we are talking about that. We are talking about preventing the disease process in the first place. But really, what we're talking about is that we're talking about preventing morbidity and mortality. So, morbidity means like disability, getting sicker and sicker, um, not not dying, but no longer being an active, involved participant in society. Mortality, of course, is death. So we want to prevent death. We want to prevent morbidity as well. And so that's really what we're looking at. And when we talk about the primary level and preventing the problem from ever starting, we're saying if it never starts, you're not going to get super sick and you're not going to die from this problem. Okay. So, one example of primary prevention is vaccines. Don't get it in the first place. Now, as you know, since we've talked about COVID, we might as well bring this up. At the moment, the COVID vaccines do not prevent anybody from getting COVID. It prevents you from getting it super severe and dying. So there's different types of vaccines, and it's important to understand what the goal of that vaccine is. For example, chickenpox. We want to prevent anybody from getting chickenpox. So we give them the vaccine. They don't get the disease process. That means that they don't get all of the scarring from scratching at the chickenpox. Um, a lot of people will have chickenpox parties when their kids are really small, so that they get them. They can wrap their little fingers. They're not scratching themselves, and it's fairly benign. Um, Mumps, measles. Back in the day, I got smallpox vaccination when I was a kid because we were working on eradicating the disease process because there was a lot of morbidity and mortality related to smallpox. And so it was important to totally eradicate that. I think we eradicated that in the 1970s, 78 or 79, something like that. So because the disease is basically eradicated, kids don't get vaccinated for it anymore. When we talk about viral warfare, that's a whole separate topic. And those vaccines may come back. Anyway, separate discussion. Okay. That's primary. Secondary prevention is talking about screening. Let's see if we can catch this disease process really early. So you go to the doctor, you're in your 40s, and we check your blood sugar, your fasting blood sugar. Oh, it's 322. Wow, we have a problem. Now we're going to have to deal with it. Then we're going to get into tertiary prevention. And we'll talk about that here in a minute. Or we go to the doctor and we're in our 40s and we're a woman or a man and they do testicular exams and breast exams. And it's like, you have a lump. We need to get after that. Or we just need to do a mammogram. We just need to just check it to help me catch, if we're going to catch the breast cancer or testicular cancer, let's catch it really early so that we can deal with it so that your likelihood of dying from the disease is pretty slim. All right, then we get into tertiary. Now you've already got the diagnosis, right? So let's go back to diabetes. We went to the doctor, we were screened with a fasting blood sugar, found a blood sugar in the 300s, and it's like, uh-oh, we have a problem. So now we're going to teach, a lot of teaching. We're going to talk about diet. We're going to talk about exercise and activity, and we're going to talk about medication that we're going to give you to lower your blood sugar. And so every physician's going to have a different idea, but we're going to attack that and see if we can get them to lose weight, be more active, burn off those sugars, take the stress off the pancreas, and poof, they may no longer be truly a type 2 diabetic. They might in 20 years, but they might not be now. So the sooner we can get these sugars under control, the better impact we have on morbidity and mortality, because they're less likely to become a dialysis patient and lose their kidneys. They're less likely to lose their feet, so on and so forth. All right. My first, everything that has the one behind it came from Tabor's Medical Dictionary. That's my first reference. My second reference is I'm using a pathophysiology book, happens to be the 5th edition by Kopstead and Banasic. And there's probably a newer edition out there, but some of these things in pathophys just really haven't changed a lot. And so I'm sticking with my current book. All right. I want to say thank you for listening to the entire video. I hope this was helpful. My goal is to try to take some of these topics, make them really simple, and make you go, "Oh, that makes perfect sense. Now I get it." Because sometimes just reading the book, you're like, "What is this?" And same thing sometimes with certain professors, it's hard to grasp. So if you got something out of this video, if he found it was helpful, I have 2 requests. One, please subscribe to my YouTube channel, of course, because I wish to continue doing this. And number 2, if there is a specific topic that you're having a challenge with, I would really like it if you would email me, and I will work on throwing a video together to address that for everybody. But I will also email you back and see if I can help and answer your questions within 24 to 48 hours. All right. Thank you so much. I hope you have a great day.